Hi, everybody. Here we are. Ask the Expert Part 2. I won't. I'll let everybody introduce themselves here because our panel has grown from last time.
Hi, I'm Dr. Eggitt. I'm a GP here in Doncaster. I'm also the Chief Executive Officer of Doncaster Local Medical Committee.
Hi everyone, I'm Joanne. I'm a pharmacist and I'm the Chief Executive Officer of Community Pharmacy South Yorkshire.
Good afternoon everybody, my name is Richard Denton. I'm currently the Secretary of Doncaster Local Dental Committee and I was a dentist, one of those rare things, an NHS dentist for 37 years before I retired about 5 years ago.
So, like last time, it's got a little bit of structure, but I think we said it last time that there's no question that you can't ask. You know, go for it. The more interesting ones, the better. For those that saw the adverts that we sent out there, we did say, you know, that there was from last time a hack. So I did think that Dean better go back and say the hack of getting the best out of your GP, which is ice, that I can't remember what it is. So if we start with the hack for those who have just come for that bit.
Yeah, sure. So I'll recap about the hack for GP. So this is the concept of getting the best out of your GP consultation. It's actually a communication, not really tool, but something that we use as when we're taught communication as GPs, how to get the best out of the patient. But actually, I think it can go both ways. I think it's also a great tool to get the best out of your GP or actually indeed your pharmacist or dentist or whomever actually you're having any sort of transactional relationship with where you want something. So ICE stands for ideas, concerns and expectations. So from a GP perspective, we're supposed to have this 30-second to 1 minute golden time where you begin the consultation. Somebody can talk openly and freely, pretty much with full reign of whatever they want to for 30 seconds to a minute. And at that point, I'm supposed to start understanding what the theme of the discussion is. I'm then supposed to start to guide the discussion. And part of that guidance is this ICE, the ideas, concerns and expectations. So ideas is what's going on in my patient's mind? What are they thinking about? So coming into this, from that first 30 seconds to 1 minute, I'm supposed to have a clue, but actually I'm supposed to make it explicit and actually ask. So what's going through your mind? What are you thinking about? The second part of that is concerns. And that's subtly different to what are you thinking about. It's, okay, you might be thinking about it, but what's scaring you? What's making you anxious? It's almost the motivator. What was it that made you take that step of coming to me today? And the third part is expectation. So you've got these ideas. Something made you take that step of coming to me because you were concerned about it. And you want something now as a consequence. That's your expectation. Well, what is it? So rather than me guessing, I'm supposed to ask almost explicitly without you noticing. Well, actually, I kind of want you to notice. And I'm flipping this on its head. Not only do I want you to notice, but I want you to use it. I want you now to go to your clinician and say, these are my ideas. This is what I'm concerned about, and this is what I expect out of our consultation today. Because let's be honest, if we both agree on the ideas, concerns and expectations, everyone should walk away happy after negotiating what the outcome is. And most consultations that fail because there's been a misunderstanding. Well, actually, we can get rid of that misunderstanding if we both agree that we're going to tackle the ideas, concerns and expectations. It will get you faster to where you want to be, and actually where you want to be rather than an assumption of where you want to be.
I'm going to go off script straight away because I know one of the questions for the GP is why do I have just one ailment per 10-minute appointment, right? So my question is, if I throw that at you now when you've just talked about the ICE bit, because, okay, 1 10-minute, one ailment where there's a lot of things that are actually connected, so why can't we look at all of them? Can we use ICE?
We can, yeah, and you know what, rather than pinning that completely on me as the GP, I think that applies to all of us. Because there's no way that I'm the only one that somebody's come in with a whole list of stuff. I suspect this has happened to you guys too. And it feels like this torrential downpour of information. And like any torrential downpour of information, first of all, it feels overwhelming. You've got to remember it. You've got to pick up the salient, scary features about it and what to address. And in medicine, nothing is easy. You might come to me with what you think is possibly a broken toenail. Well, to you, it's a broken toenail. To me, it's potentially cancer. And I've not now got to spend the next minutes trying to figure out, is it just a broken toenail? or is it cancer? You say to me, oh, I've just had this little cough for 3 weeks. Is it just a cough? It might be an irritation to you, but to me, it might be a blood clot on the lung. So I have to spend all of that time trying to figuring out, are you going to die or are you okay? So every time you drop this little bombshell of, I've got this itch, or I've got this cough, or I've got this nail, each one of those to me is death, death, death. And I've now got to spend all of the time thinking out, are they going to die or are they not? And every single time you tell me a new symptom, I'm scared for you until I've asked enough to figure out, are you okay? So for me, that one problem, one consultation is not really one problem. It's use that 30 seconds, use that minute, tell me everything. But then we're going to focus on the scariest part or the most dangerous part and sort that first so you don't die. And then once we've solved that, if we've got time, we can do something else. But if we haven't got time, we're going to have to do it over another consultation. Now, please tell me that happens to you too.
Absolutely.
I've never been worried about anybody dying.
Maybe should have done dentistry instead.
It sounds a lot easier.
Risk, yeah. No, absolutely. And I totally echo what Dean said in terms of it really helps any clinician who sees you if you come in and are able to be really honest about what it is that you think you've got going on, what it is that you're worried about, and what you hope we're going to be able to do for you. I think going into a pharmacy perspective, again, if you're going in concerned about medicines, some people might be on 1 or 2 medicines, other people might be taking a huge list of them. It can be pretty overwhelming to start going through everything in one consultation. So it's very much about having that discussion and agreeing what is going to be the most important thing that we can help you with on that day. And I think keeping that at the forefront all the time is really important. What about you, Richard?
Well, I think dentistry is much easier by the sound of things. People come in and say, I've got this lost filling, you have a look and it's the lost filling. I don't have to concern myself with the toe or the... So now I think dentistry is very much more of what can I say, a defined problem. There may be instances where people come in with toothache that or other symptoms that might take a little bit of figuring out and we don't get it right every time, first time. But by the sound of the kind of things that my colleagues here are dealing with, it is very much more, for the vast bulk of the time, much more straightforward. The patient knows what they've got. I've lost this filling, I've broken this tooth, I've got this toothache, my dentures are rubbing sore. They're very, very immediate things that you can identify without having to worry about all the other myriad of things like my colleagues here worry about.
One of the other aspects of this, though, and I hope you don't mind me interjecting and picking this up, though, is this concept of decision density. And I suspect that probably does apply to dentistry. Density, which I suspect does apply to dentistry as much. And it's, again, the more information I get, which is great because I've now got information to make decisions, but the more you give me, the more I've got to think about. The more I've got to think about, actually, the more it overwhelms my brain. And the more my brain is overwhelmed, the more dangerous I become. So if you give me too much to think about, it can be too much to come out with a safe decision. I know full well that applies to pharmacy. And I suspect, again, that applies to dentistry. If you've got so much going on, it's quite hard to make a decent, clearly defined decision. So whilst it might not be 2 or 3 things in a consultation, the amount of information that you've got to sift through can affect the safety of the consultation. It can't be so little that you can't make a decision, but it can't be so much that you're overwhelmed and you can't see the forest for the trees.
In general, if you got too much, would you tell the patient, though, let's deal with this and book another appointment and we'll come and see to that then?
Yes, yes. And that's where...
And I know booking an appointment is hard enough, but we can come to that later.
But that's where the conflict occurs, isn't it? Because if I say, well, you know, that's too much or there's too many things there, book another appointment, what I haven't explained to the patient is why that's important. All I've just said is too much, book another appointment. But there is reason, method behind my madness. I've not done it because I'm being mean. I've done it because I'm keeping me safe, I'm keeping you safe, and we want the right diagnosis rather than a flippant answer. I can give you flippant answers all day long, but quite frankly, at some stage, you will suffer as a consequence of it, and that's not okay.
So it is all about relationship.
Yeah.
I'm now going to go back to explain how we're going to do today. So I've got it, I think, in 4 topics, as long as I can count. General, we'll just do dentist, pharmacy, GP, and mixing it up. General questions. Then going to look at men's health specifically, women's health specifically, and then youth. And I will say, no, there isn't enough time in the day to cover all of that. So it will just be, what we can get along with, sort of thing. So I've got lots of different questions. I'll try not to focus on one of you because you might get bored of just listening to one person. But the question that I do like, so I'm going to go to dentist first because I always like to get to the point. And I think is a good question that if you expand on, which is the question of, if I phone a dentist, okay, and ask for an appointment on the NHS, why is it I get told no, but in the same breath almost, they offer me a private appointment? Are you just in it for the money?
Yes. Is that my question? Have I finished now? Access to NHS dentistry is a really big topic. And we could probably spend half an afternoon addressing that, because like most things in life, most systems, you don't have problems just for one single thing. I've thought about this, and there's probably 10, 12 different elements to it all. One of the elements is that practices, well, firstly, there is no such thing as an NHS dental practice. They're all private. They're all privately funded. The staff are paid for by the dentist. There's no NHS employees in a general dental practice. But what practices do have, they may well have a contract for a defined amount of NHS work for a year. So they'll have an amount of money. There's targets to hit. Without getting too much into the weeds, these are called units of dental activity, and you have a unit of dental activity is worth an amount of money. You multiply that up by your target and you've got your contract value. What dentists are meant to do is they're meant to eke that out over 12 months. What you're not meant to do is go hell for leather, do it all in 6 months, and then not have any NHS capacity for the last 6 months of the year. So you're meant to eke it all out throughout the year. There are staffing issues in dentistry, getting associates. So you've got practice owners, you've got associates. Getting associates to necessarily work on the NHS. One thing I was telling Rachel about when we're walking over, it's not something that in my time in dentistry, because I qualified in 1983, but a dental student now will often leave dental school with over £90,000 worth of debt. So when you look at what the interest rate and paying that back, that's something like £600, £800 a month. So that factors into younger people's thinking about the kind of work that they want to do, the kind of work that they can afford to do. And to answer the question more specifically, there might not be anybody in on that day. Practices will have a mix of staff where some may only work privately. So there might not be any NHS capacity to see a new patient with toothache on that day because that person's not there, that person's not available. So it is a tricky one. It is one that I know does cause a lot of trouble, and rightly so, because people think, well, why is it? Is it all about the money? Money comes into everything because you are running a small business, and if at the end of the year you've not made enough, then people, the practice folds, people lose the jobs, that kind of thing. I think I've probably said all I can really say. Has that, do you think?
I think that's answered most of it.
Would anybody like to ask me anything about that? Have I been?
I will then follow on, seeing how you've mentioned the fact that you are a private business. I'm going to ask the pharmacist over the fact that once upon a time, I'd go to a doctor, I'd get my piece of paper, or I'd get the prescription, I'd walk into a pharmacist and you'd give me that. That is what, a long time ago, I'd say a pharmacist is. What is a pharmacist now, and is that all that they do?
No.
And basically, the private business, do they work for the NHS? Explain, what is a pharmacist?
So firstly, a pharmacist is an individual who will be responsible for the running of a community pharmacy. So the community pharmacy is the entity where you would go into as a business And that's where you will go and get an NHS prescription fulfilled if they have a contract to do that for you. They might also sell medicines over the counter or offer a range of private services. But increasingly, certainly over the last 5-6 years, we've seen an increasing range of NHS services now being offered through community pharmacy. And that's both from pharmacy professionals that work in there, so we have pharmacists, and we also have pharmacy technicians, both of which are registered health professionals. So you've already got 2 different categories of professional in that pharmacy setting, and then other members of the pharmacy team who will have key roles, whether that be assembling, dispensing medicines, or whether that be actually doing the meeting and greeting at the counter, helping to signpost people to different services. So there's a lot more to it, Fran, than just going, taking your prescription, getting your medicines and walking out.
So, okay then. So a few other questions. Where were we? I like going back to the dentist. I'll come to you later. You had a whole time last time.
I'm fine. I like just sitting here.
So, one of the questions that we had for dentists as well is if you phone 111 and have an emergency appointment, okay? What we get to hear a lot of, and one of the questions in this, is you get to see a dentist who does something for that immediate. And then you're left having to go and find a dentist to sort out the rest of that. You can't find an NHS dentist, and all of them then offer that they'll sort it out privately. So often you feel in a worse place going, I'm now skint, I've got half something sorted, why on earth did I bother? So the emergency dentist, what's the point? I think that's the way it put. Oh look, I've got a lot of nods, so I'm not the only person.
But you wouldn't be saying that if they got you out of pain?
Yeah, if they get me out of pain, that's great, but then it's not fixed.
No.
So why not?
Because at that point when you've had that emergency dealt with, you're just back in the general population, and I'm answering the same question that I've already answered. So out of hours, evenings, weekends, whether you've got a dental practice or not, if you're unfortunate enough to have severe toothache, these kinds of things, the place to ring, the number to ring is obviously 111, and they've got a bank of dental nurses who are trained to triage what that problem is, and if they feel that you need an appointment, then organise an appointment in a local emergency clinic. Doncaster has 2, I think there's one in Thorn and one at the Flying Scotsman Centre. But sometimes there's contracts for these. There's a company called Roderick's Dental Partners that I think has a lot of the contracts in South Yorkshire. So it may be that you go to one of these clinics that, or in Doncaster is full, and you might be asked to go to Sheffield or Rotherham, which is less than ideal if you're trying to do that on public transport, whatever. But again, they've got a finite number of appointments. I'm not aware of the kind of things that they would say would need an appointment. I'm guessing if you've just chipped a tooth and you're not having any pain, they're probably, unless they've got a ton of unused appointments, they're probably not going to offer an appointment. The kind of things for, like, let's say lost fillings, that kind of thing, you're not going to get a permanent filling done. You're going to get something that's of a temporary nature to solve that problem. But then we're back to the first question, where access to NHS dentistry, all the same answers that I've already given you. It may be. So if we go back probably a couple of years, there was a practice in Armthorpe where they lost a couple of dentists very, very quickly, and they were both NHS dentists. Somebody retired, somebody moved. They would just not have the capacity to do, and then you say, well, what about the private? But they might have dentists that are just working privately in that building. And so they said, we can't see on the NHS because we're 2 dentists down, but Mr. Thing here, he works Thursday, Friday privately, we can have an appointment with him. So when you can't get one, there's a whole myriad of reasons, but the 111, if you've got banging your head into a brick wall toothache, well, they'll sort that out. But then after that, yes. Now there is a scheme in Doncaster, it used to be called flexible commissioning, whereby a number of practices were, by working differently, were allowed 10% of their normal contract value not to have to do as these units of dental activity, as I was telling you about. And one of that elements was access. They also took referrals from school nurses or health visitors, these kinds of things for children. Currently, that scheme is no longer called flexible commissioning, it's called Prevention and Access Scheme. There's now only 5. But if you were wanting to know of a practice in Doncaster that's taking on new NHS patients, the NHS website is the place to go. All dentists have got a requirement, if they have an NHS contract, to keep their status up to date. I would say the 5 practices that are in this access and prevention scheme, they will all have waiting lists. Waiting lists could be a couple of thousand people. Oftentimes you get, what would people do? You'd probably get on all the waiting lists. So it might not be that you've got a couple of thousand, you maybe have 1,200 or something.
At this point, I know the answer to this, but can you explain? Because I would go to a doctor and I would fill in a form and I would register with a GP, okay? That would be the way that it works, right? You generally go to the one that's nearest, you can go to a different one. Do I register with a dentist?
Absolutely not. So
and that's something that I think the general public don't realise.
You would naturally assume it's just the same as being with a GP. The amount of time since the NHS came into being in 1948 till today, the amount of time that you did actually register with a dentist or with a dentist with a dental practice was 1990 to 2006, and that contract that was in place at that time. You did register. Dentists used to get something like 57 pence per patient per year. Children were done slightly differently on a capitation basis. There was no limit to the number of people that you could actually register. One of the problems with having registration from a government point of view is that it was a stick that people were able to beat them with when they say, but there's only 47% of the adult population registered with a dentist, and there's only 60% of kids, what have you. One of the problems is when we worked for like forever on fee per item, just like the rest of the economy works, the dental budget, the amount of money that dentists earned, has only ever been treating like half the population. So the budget, now that the budget is fixed, it's only enough money to treat half the population as the population was in 2007. Because the dental budget, believe it or not, has not changed one iota. I'll tell you what has changed, the amount of money they take through patients' charges. That used to be about 400 million a year, it's now 900 million a year, because they've been going up. But the actual amount of money available for NHS dentistry is just the same as in 2007. But during the meantime, of course, the population's larger. As I was talking to a friend this morning who he was saying he'd broken a tooth and needed a crown, I says, yeah, that's all right, Graham. But I says, when you were, and I told him I'm coming to you today, I said, when I was a kid and I'd be doing somebody your age's teeth, you didn't have any teeth. You had a set of full dentures and you needed a new set every decade. And that would take probably an hour. So their demands on the system were an hour once a decade. Graham's crown's going to take probably an hour and a half. That's just one go. So there's lots of things in play, but in short answer, you're not registered with a dentist. The government has an expectation of a notional list. If you've been for 2 years, they regard them as your practicer's patient. But at the end of each course of treatment, that's it. You've got no official affiliation with that practice.
Right. I'm going to stick with the theme of money, and I know that this is a question with money, and I'm coming to you. Okay, so now this is perhaps simplicity. I hear that we've got unemployed GPs, okay? I hear that we've got a lack of GP appointments. So I've got this great idea that you as a practice owner or whatever, why don't you just employ a GP? Because wouldn't that solve it?
Okay, yes. So much like dentists, GP practices are private. So when the NHS was set up, GPs stayed out of the NHS family, and we have a contract with the NHS to deliver care to patients. So we are bound to the terms of the contract. So the government will decide every year what's in the contract and how much money to give us for patients. Unlike dentists, we have quite a lot of boundaries in that contract that stop us working elsewhere. So we have extremely limited financial input outside of that contract. So even though we're private with an NHS contract, we can't really do any extra private work on top. We can do a very small amount within certain limits, but we can't just go out there and do a load of work to bring in extra cash. So we're stuck really with whatever the government gives us per patient.
How much is that?
It varies from location to location across England, and it varies based upon your patient cohort where you are. So how old your patients are, how rural they are, how deprived they are. So there's a formula to figure it out. But if you guesstimate that one patient in the NHS to a GP practice attracts a fee of roughly £150 a year. Now, for £150 a year, you may never see your GP or anybody in your practice, and therefore that is money that goes into the practice that pays for the running of the practice. Or you might have a patient who goes 30 or 40 times a year for that £150. So it all sort of comes out in the wash where it middles out. So if I was being really blunt and rude, I would say as a GP practice, I want patients who are young, fit and well, who do not come to see me, and I want as many of them as possible. Because I'll get loads and loads of cash, I can build a beautiful building, you'll walk in, there'll be gleaming marble everywhere, and I'll turn up in my Ferrari, and I'll have no patients to see. That is the nirvana. That's what GPs are looking for. Whereas in reality, what we have is a growing population in England, an aging population in England, for all the right reasons, because we've been more successful in treating diseases, we have antibiotics, people are living longer, people are working longer, that's great, but with all of that comes extra diseases. With all of that comes more appointments in the NHS with your GP practice to keep you healthier, fitter for longer, or if you're not healthy and fit, we keep you plodding on as long as you can. So you don't see us 3 times a year anymore like you used to. You might see us on an average 6 times a year now. So the average number of times you go to a GP practice has slowly crept up. So we've got older patients, sicker patients, and more attendance at the practice. More money has gone into the NHS and has gone, in theory, into general practice, but hasn't gone into general practice pockets to spend. So that money that's come through, that's been invested in general practice, it's almost like the best description I've been given so far is if I tell you to go paint your house, and I'm going to give you paint to do it, but I'm going to give you 50 tester pots, and that's all you're going to get. Make it stretch. That's it. There's no money. I'm not going to tell you to go out and buy your own paint. I'm going to give you these pots, and they're very specific, and you've got to make it stretch, and you've got to make it last. That's kind of how finance works in general practice. Here's your pot. Here's how to spend it. Make it work. So I don't have spare cash sat around to employ a GP. What I've got is money in an account that I can spend upon a pharmacist, upon a physiotherapist, upon a counsellor, upon the building rent. But that money cannot be used for me to buy a GP. So I can spend it on my staff, and whatever I've got left over, quite frankly, is not enough to afford a GP. So GPs are going unemployed because practices can't afford to pay for them because we have allocations for the money that we're given.
Okay. Anybody got anything else to ask on that one? So, I'm going to take it because first of all, the question is, am I right? Which is a yes or no, which then I'll explain why. So, am I right that pharmacists and GPs will have, when it comes to such things like checking blood pressure and such things as vaccine, you both have access to that same pot of money? Am I right that that is sort of the case? Because if I am, my question then is, doesn't that put GPs and pharmacists absolutely competing with each other for the same pot of money? And if that is the case, how on earth does that benefit the patient? You two being in...
Do you want to take this?
Yeah, I thought you'd pass it to me. Yes, kind of, but The vaccination service is different to what you've described with blood pressure. And if we could do a whole day on pharmacy funding, and I would probably need somebody with far greater expertise than myself to get into the intricacies of that. But if we take flu vaccines, for example, yes, what you've just described is kind of the scenario we find ourselves in. And it's a bit daft, basically. But if you think about it, if you've got two professions that are both striving to actually get more people vaccinated, ultimately you're going to end up with a population that hopefully will have a greater vaccination rate. So there's kind of a bit of an incentive there from a government perspective, I guess. But is it right that if I'm running my pharmacy that's next door to Dean's practice, which it isn't, by the way, but if it were, is it right that Dean and I would be in competition trying to pull people off the car park to come in through our door to have their flu vaccine? And that's the reality that we are kind of seeing play out in real life at this moment. And the reason that that's significant is because the money that comes into both professions is so critically important to them to keep their private businesses open. Now, it would be lovely, and I think we're both on the same page with this, to have some form of commissioning arrangement where it'd be great if we could work together. And Dean said, well, do you know what, Joe? I really struggle to get this list of people to come into my GP clinic for flu. How about you have a go and trying to contact them and see if they want to come into the pharmacy instead? And I go, yeah, you know what, that's great. And actually by the end of it, we get as many people vaccinated as possible and we do a bit of a gain share in terms of the money. That to me would make better sense. I'll probably get myself shot for saying this publicly, but that to me has got to be something that we need to strive towards. The challenge we have is that because the contracts are all built in their silo, you don't always get that very joined up thinking. And blood pressure is another really good example of where that joined up thinking doesn't really work. And the idea has been that, yeah, you know, pharmacies are really accessible, be great. They've got a key role to play in terms of trying to help prevent people from getting poorly. And actually, yeah, go into a pharmacy, get your blood pressure checked if you're over 40 and you've not had it checked for 5 years. That's a great idea. But what's happening is it's creating work that is then transferring back into general practice, and there's no remuneration attached to that for general practice. So we're solving an issue in one part, but we're creating an issue in another part of the system. And again, we just need a little bit more joined up thinking. I've answered that in a very simplistic way.
No,
you may well want to add into that.
Joe answered it in such a beautiful way. Well done, and politically correct too. I'm less politically correct. So to be slightly more blunt about what Joe has just really beautifully said is that if in a pharmacy, Joe perhaps is in her pharmacy one day and she checks somebody's blood pressure because it's good clinical practice, it's great to do, and she gets paid for it. Why wouldn't she? Her role then is to pass that number to me for me to do something with. Now, I'm not paid to do anything with that number. All that's done is just turned up the number of times that my patient turns up to me. And I've just told you what the nirvana is. The nirvana is I want healthy, fit people who don't come to me. The last thing I want is Joe finding 1,000 more people to send to me. And that's exactly what she's trying to do.
Yeah, do it.
Your pharmacy cohort are going out there looking for sick people and saying, here, come and see Dean. Now, that's clinically the right thing to do. It's brilliant for patients. It's brilliant for healthcare, and we should encourage that. But the contracts and the financial movement are perverse. It makes me hate it because I can't afford to deliver the service because I can't pay for a nurse. I can't pay for a doctor. I don't have the staff to deal with the thousands of people you're sending my way. And that's the issue. Really, the resources and finance need to follow the patient. And we don't have brilliant communication at the top level in England of the people negotiating these contracts. So Joe's senior team will negotiate a contract, and on paper it looks brilliant. Yes, we should do that. But they won't talk to my team. My team will have no idea that we've just been stitched up.
And vice versa.
Yeah, of course. Yeah. Not just blaming pharmacy there. So because, thank you. Because of that lack of joined up thinking, we have animosity towards patients, which isn't right. We have a system that doesn't work and doesn't benefit clinical care for patients.
just to be unpolitically correct, and we've also got dentists at the end there, that I can come and see you and it's free, okay?
Yep.
My NHS is free. I can go to Pharmacy First, which we'll come to in a minute, and it's free. I go to an NHS dentist and I'm paying. At what point is that community and there?
Do you want to know how that came about?
Oh, go on. Does anybody else want to know why we pay for the dentists and nobody else?
Before you do, Richard,
Yeah.
I have to say, it's not free. It's not free. It's free at the point of access, but it's not free. You all paid for it through high taxes, and we've just had a budget, so we know how much that is.
So we all get taxed more as from
Yes,
June, don't
yes,
we?
yes.
So you should be getting more money. We won't answer that one. So why do we pay?
So in 1948, there was a guesstimate about the amount, because up until that point, all dentistry was private, and there was a guesstimate about how much work was out there to do. There was a ton more than anybody guesstimated. There was an awful lot that was being done. And so by 1951, they realised that they've bust the budget, and so they introduced patient charges called a co-payment, I believe. And the purpose of the co-payment is two things. One is damp down demand. They knew that if you introduce a charge, the number of people going through the system will go down, and also to rake in some money to help pay for the system. Like I said, it's 900 million out of 3.3 billion. So it's give or take a third, isn't it now? There are exemptions. There's certain benefits that will exempt you, pregnant and nursing mums. So there are exemptions where it is free, but basically, and this causes, patients' charges cause, as I've alluded to earlier, conflict in contracting, because the government is dependent on them. They don't want to spend any more. And so any change that they put in where the patient's charges are at risk of dropping, then that causes tension in the system. So yeah, it was free for 3 years.
3 years.
And it's never going back to. I mean, does everybody know how much the patient's charges are for the different bands of treatment? So if you were to go to 111, that would be £27 and some pence. If you go for a band 1 treatment at your dentist, which includes checkup, x-rays, scale and polish, that's a band 1, that's £27 as well. If you then need anything doing, like a filling, this is where patients can benefit to a point. So if you need 1 filling done, you're in a band 2, that's £72 and some pence. If you need 2 fillings done, it's £72 and some pence, 3, 4, 5. But up until relatively recently, where there has been a little tweak in the system, you've got patient and dentist, doctor and patient at loggerheads again. Somebody goes in and needs, I mean, this is another point about access. If you're taking an unknown patient on that might need 6 fillings, you're only going to get paid for 1. But that patient is going to take 6 times the amount of, maybe not 6, but 3 times the amount of time that person that's so a bit like you want in healthy patients. Dentists are just the same. They don't want people that need a boatload of work. Now, there have been methods of trying to adjust this, and can I blow the trumpet for South Yorkshire Integrated Care Board, because last year they end up with what's called non-recurring money in their budget from dentistry. This is money that they might have clawed back out of practices, or practices have said, have that contract back, we're off. Well, last year they had £12.5 million non-recurrent funding in dentistry. If they don't spend it, all that money is lost out of dentistry. It just goes into the Treasury's black hole. So the people of the dental team of South Yorkshire set about spending it by buying access sessions. So there were, I don't know how many of these contracts are left now, if any, but there were contracts put in place where practices were given a sessional fee, and 111s, or they took walk-ins, 111s were directed to those places. The government in its election manifesto promised another 700,000 extra emergency appointments. Has anybody heard of that? So they set about trying to encourage ICBs to do this, South Yorkshire was already in a bit of a problem because it doesn't have 12.5 million non-recurring. It's got something like 4. So pressure was being put on. The 48 ICBs, something of that order. So up until probably about 4 months ago, none of them across the country were meeting their target for these extra 700,000 appointments. South Yorkshire got something like 20,000. And I felt sorry for the people working in the ICB because their target had been set on last year's target where they'd had 12 million to spend. So central NHS is saying, great, you did that last year, but you've only got 4 million, but we'd like you to do that and another 20,000, which is just a complete ridiculous notion that you must come across that kind of thing in your, all the time.
Yeah, the target setting via central health management in England seems very out of step with local understanding. Yeah. So for us as a frontline clinician, we think our job is hard. The people who organise behind the scenes have an absolutely untenable job. It's just impossible to deliver the national expectations. And frustratingly, every year, of course, our politicians say, we're going to give more, you're going to get this more, this is going to be extra, because it sounds good to taxpayers to say you're going to receive these extra bits and bobs, so it gets votes. But the reality is the people who organise it, they know it's untenable, and us at the front on grassroots also just can't deliver that. So we're constantly trying to catch up to these promises that are undeliverable.
I think we could get political all day, so we won't.
But can I just interject?
Yeah,
in dentistry, it's both the blues and reds. It's not just one. This has been going on since 1992. The gradual slow demise of NHS dentistry is both parties. It's not just one.
And I would echo that for pharmacy as well.
Same for general practice. You know, there is no one political party where we'd say we desperately need them to take over because they're good at it. Everyone makes promises that are unrealistic.
And uses you as their campaign of why they're going to get it right until they're here. And then they look at the coffers and do exactly what everybody else has done before.
Yes.
So, but we will move on. Okay. I'm going to come to pharmacy. I'm going to come to the question of pharmacy first. Okay. Great. You know I have thoughts on this one. I see it that I can walk into a pharmacy. Okay, so the question is, what is pharmacy first? But I can walk into a pharmacy and I can ask the pharmacy anything, the pharmacist anything, right? That's free, pop in, do anything. In the same advertising, I can go to the pharmacy first and book an appointment. Then I go to the GP to book an appointment with you. I don't understand it. I'm confused. You've explained it to me a million times. The question that we got in, what is pharmacy first? And we haven't got that long.
Yeah. Pharmacy First was a government-led, very much a government-led initiative. It was Rishi Sunak's priority to get a Pharmacy First service in place. And I think it's fair to say there are different schemes that run in the other countries. So Scotland's had a Pharmacy First service for several years. It's very well renowned and has quite a large evidence base behind it in terms of the difference it's made to access and for people to be able to get timely advice and treatment. Wales also has a service. England has one, and guess what? They all look different. They all look different. The principle behind Pharmacy First is around being able to do exactly what it says on the tin. Instead of bothering Dean, come see me, I'll deal with it into the level of my expertise. I'll be able to give you either some reassurance, some self-care advice, and for certain things within Pharmacy First, we're now going to let pharmacists be able to give you some prescription-only treatments. But that's all tied up within really, really tight frameworks to keep everybody safe, make sure that we don't cause a massive problem giving antibiotics out willy-nilly. So that was the general gist of it. The execution of it leaves a little to be desired. And I'm not going to be politically correct now. The communication out to the general public about it, let alone the profession who were expected to pick this up with a month's notice, was pretty lacking and still continues to be lacking. To sum it up, there are 7 conditions that you could just walk into the pharmacy and ask to be seen under Pharmacy First. But each of those conditions has different criteria attached to it. So if you've got an earache, for example, if Fran has earache, you don't bother coming to see me because I can only see you if you're aged between 1 and 17. So I can't see you as part of that service and be paid for that. So that sends you straight off to bother Dean, okay? There are 7 conditions that you can walk in and ask for that advice for, but you have to remember which bits you fit into. And this is why sometimes we'll get queries that'll say, well, I went in and asked about, a sore throat, but I couldn't be seen. Well, it's probably because you haven't fit one of the eligibility criteria that the pharmacist is so tightly bound by. The other part of the service is that other places can refer into the pharmacy for them to have a chat with you and consult with you about any minor illness. So whether that be a verruca, athlete's foot, an itchy patch of skin, but you can't walk in to see me for that and I wouldn't get paid for it. You've got to go to Dean or you've got to go to A&E or an urgent treatment centre, and they'll then send a formal referral into the pharmacy. Kind of see where it falls down a little bit. But again, it all comes down to, this is I suppose the fear factor of what would happen if they opened it up and what would that do to the budget. We all know the NHS has got a defined budget. It's not a bottomless pit. So a lot of these controls have been put in there. Number one, to keep people safe. So to make sure we don't get rogue pharmacists doing things that they don't have the competency to do. But also, a lot of it is about financial control and being able to define the spend for Pharmacy First. They've then put caps on the number of consultations that a pharmacy will get paid for per month. So you're disincentivising, you're giving in one hand and then you're disincentivising with another. I'll go on record, it's completely ridiculous and it needs overhauling. This could be something we could make a really big difference with. And if Wes was sat here now, I'd be badgering him to death about it because, but it is one of the most simple things, and it would help so many people out there where we've got areas where there's huge health inequalities. Pharmacy is generally within a 20-minute walk of most people of where they live. Generally, it's people that you might have grown up around. Pharmacies that I've run in the past, they used to come in and refer to the staff as Auntie Jill, and they've got that kind of relationship. Why can't we enable them to put the proper support in and stop people rocking up at A&E for paracetamol suspension for their kids? It just beggars belief.
It reminds me of that image. I'm sure we've all seen this picture of a pathway where an architect has done this beautiful pathway around somewhere, but actually there's a grass and somebody just cuts across the grass. So people have gone across the grass so often that it's created this new pathway. So you've got this understanding of it to such a detailed extent. You make this beautiful thing, but it doesn't actually work. People don't need that. What they want is the path of least resistance to get to where they want to go. And that's why we still have patients who are unwell with something that's minor, that your pharmacist is over-skilled for, can help very easily, but actually it's just easier for a patient to go to A&E. So A&E is the default because it's easy. We all know A&E. We know where it is. We know how to get there. We know how it works. Whereas actually getting into this scheme is complicated and it might fail. Why would I go to this scheme? Which is insane because actually it's perfectly suited in the pharmacy if we design it that's suitable for patients, but we haven't.
So Dean and I need to redesign it.
So ultimately, what we need to say to Wes out there is you need to put the pharmacists, the GPs, the dentists and people in a room, all working together, ask us to design it and we'll solve the issue.
And give us the freedom, because I don't want 1,000 pots to paint my house. I want one pot and say just go and do it.
And you lot all working together,
Absolutely.
or all of us working together,
Yes.
would solve it.
Yeah.
There you go. And of course, Wes will be watching this later.
Brilliant.
Absolutely. So, I was going to go somewhere else, but I'm not now. I've got a couple of questions. I do know that Cheryl's holding something pink, so it might be there. But I do have something. Lai, you asked a question generally. Do you want to ask all of this lot?
It's to do with self-prescribing. How's the practice, getting on with that? And is it doing well, or how's the pathway?
Okay. Thanks. So, social prescribing is something that's reasonably new on the block.
What is it?
That's what I'm coming to. So I would say, so for those of you who don't know, patients who come into general practice don't come in saying, I've got elbow pain, I've got chest pain. They come in saying, oh, I've had a bad day, I feel rubbish. And then it's my job to sort of tease it out to them what's going on. Sometimes that elbow pain actually isn't the problem. The problem is that there's some stresses at home. They've been doing some DIY because they can't afford, for example, to fix their boiler. They can't afford somebody. So they've been doing something makeshift to try and help. So the elbow pain is really a symptom of the problem. They came with elbow pain, but the issue was their house is in disrepair. And their house is in disrepair because there are financial challenges. And there's financial challenges because there's a relationship problem. And this is the reality of general practice. Most people's symptoms are based upon their social circumstances. That's often to do with education, relationships, and finance. GPs are not great with that.
You
may have noticed. I want the Ferrari, I just don't want to solve your social problems. So we're not educated with it particularly well. I might be getting better, the profession might be getting better at figuring out that the elbow pain has something to do with the social circumstance, but certainly I'm not great at solving the social circumstance. So what we have developed over a number of years is people who are far better at solving the social circumstance, because there are many voluntary sector charities out there, private organisations, support groups, that quite frankly, I as a GP don't know, and it's not my speciality. So instead we have a social prescriber who can sit with the patient, have a chat, understand the situation and say, this service is available for you, it may support you, it may help you. That may be looking at loneliness, finances, housing circumstances, all of those social problems that led to the elbow with which they attended for. It's brilliant, except actually embedding it into general practice is a lot harder than it seems. So your question was about how is it working in Doncaster. We've had some challenges on who actually delivers the social prescribing, because there are several different groups and there is no one group that we've said, yes, you're the group that's doing it. So there's something about who's doing it, there's something about the quality assurance of how it's being done, and there's something then about monitoring the consistency of is it being done and is it being done well, and is it actually having the outcomes that we need it to have. To answer your question, I think I need to be able to say, what are the outcomes and is it good? And I don't think I can, because I don't think it's been embedded well enough and monitored well enough to actually know if it's doing the service it's supposed to do. From a more human-to-human level, do my patients speak highly of it? Yes. Patients are really happy that I solve the elbow problem and somebody else helps with the life stuff, because we all have life stuff. We just need somebody to help us unpick it. So theoretically on paper and practically on a one-to-one, the service is brilliant. Do I know that it works brilliantly across Doncaster? Not so much.
The old social prescribing was better. The new one is less.
Yeah, so the comment is that the old social prescribing worked better and the new one less so. And this is what I mean about some inconsistency, because there are a number of different providers, and that's actually different in different areas of Doncaster as well. So you may have had a new service, other areas may not, and it's different in different patches of Doncaster. Really what we could do with some oversight of that, to know that the service is going to be as good in Thorn as it is in Stainforth, and that we know it has the outcomes. We don't have that monitoring yet, so we just don't know. It's really hard for us to quality assure.
And one thing that you might not know is there was a pot for a length of time of non-recurrent funding that went into social prescribing. So there was extra social prescribing and one of the pots went.
There's a theme of non-recurrent funding, isn't there?
Yes.
Should we talk about that briefly? Because it's a problem.
Yes.
May we? Is that okay?
I mean, for the voluntary sector, it is a huge issue that there's non-recurrent funding. And often, if you've done something that works really well, you can't apply for the same thing again. You have to have a new thing with a new way of doing it, even if you can demonstrate what you've just done. So yes, non-recurrent funding, dentistry, pharmacy.
Absolutely for pharmacy.
Why does non-recurrent funding exist? Why is it there? I can vaguely answer the question, but I don't know if you have a better answer than me. Any ideas?
No.
So the way the the way general practice is funded, and you will know more about your areas, but the way general practice is funded is it's year to year. Every year there is a budget that goes into an area. In Doncaster, we have about £1 million a day to spend on healthcare. When you get to the end of the financial year, you either spend your pot or you give it back to the government and it goes and you lose it. Nobody's going to give money away. So as you get closer to the end of the year, you realise that you might have, was it 12 million left over? Yeah. Or maybe 100,000 left over, or actually you might have overspent. If there's any left over, it's non-recurrent funding. And it's basically, let's quickly spend it before the end of the year because I don't want to give it back. And you know what? It's right not to give it back because otherwise it's going to go back to the black hole of the government. You're never going to see it again. And next year, the government will think you didn't need the money anyway, so they'll probably pay you less. So I understand the concept of non-recurrent funding, but wouldn't it be better if we could say, actually, we don't have to have a zero balance at the end of the year. We can put it in an account and we can save it for when we actually need it. Rather than wasting it quickly on a scheme.
I mean, just like businesses do or individuals do.
I know, it's such an intelligent idea, actually, isn't it? Rather than just waste cash.
It's quite radical, really, isn't it? And the idea that, you know, if you don't spend it, you save it, because ultimately there's going to be a peak at some point. Yes. So we could spend it then.
Let's have a war chest for that peak.
We really do want us to watch this.
Well, so yeah, he has taken this on board. And do you know what they've done with this year-to-year funding? They've made it 5-year funding. So instead of going year to year, you still get it year to year, but you've got a good guess of what you're going to get for the next 5 years, but you still got to zero out at year 1. So you can't save up, but at least you know roughly what your budget is going to be for the next few years. So it's a step in the right direction. He has heard, but has he done the right thing? Absolutely not.
But the other thing is, because it comes about in such a short time period as well, the planning of how to use the money is usually inadequate, isn't it? Because it's usually a quick rally round, get business cases together. Whereas if we'd had longer to plan, collaborate, imagine what we could achieve.
We all just need to get into a room, sort it out, and tell him how to make it work. So, I know you've got a pink form. Does it sort of fit in generally with all of them? Oh, it's perfect. I knew you'd have a perfect question.
And I wrote this down as soon as I came in the room. So the new 10-year health plan talks a lot about supporting people closer to where they live in communities. It talks about supporting people really early on so they don't have to access specialist services, and it talks about empowering local people to be much more in control of their access to healthcare. So I worked in the NHS for a long time, probably about 30 odd years. And we have been trying to do this for so long in terms of a neighbourhood health service, integrating services together. And you are sat there on the stage now, 30 years later, still talking about getting in the same room and trying to work together. So I would just be really interested. Doncaster is one of 43 sites nationally that have been chosen to be part of the implementation programme. So I'd just be really interested to hear from you what your view is of that and why would it be different now than it's been for the last 30 years.
That's a lot of questions in that and a lot there. I think if we start with, because you do work in the NHS, so neighbourhood plan, okay. First of all, I think for everybody who doesn't know anything about that, is what is the neighbourhood plan? Just explain that bit first, and then go into the question of, you know, for 30 years we've been talking about it, etc. Okay, but I think what is the neighbourhood plan, and what is Doncaster managed to get into one of the top 45s of?
So the NHS is in constant flux. Every time we get a new government, there's a new plan. And even when you have a government that's been around for quite a long time, that plan will, of course, evolve because we all need to change and get better. As you've heard from us today, although we're all NHS, we're not really NHS. So the NHS is not an organisation. It is a collaboration of thousands of organisations working together. And every organisation has boundaries. It's got rules, it's got laws, it's got pots of cash. It's got people that they need to employ. It's got shareholders sometimes to pay to. Now that's supposed to seem seamless to the patient. And we struggle behind the scenes to make it look seamless because we argue amongst ourselves. And we argue amongst ourselves because of the laws that prohibit us, the rules that prohibit us, those false walls, and often the money. Because we want our share to do our job. Now, if I take my share, that depletes Joe's share, depletes Richard's share. So we're going to fight and argue over that. And that's really, really important to us because I can't do my job without the cash and I can't look after you, so we're going to fight. So we all fight amongst ourselves. Now, because of that fighting, we're not really properly working together. My GPs won't necessarily talk in a healthy way with Joe's pharmacists or Richard's dentists because of these false walls. And I'm going to give you examples. If I have a patient with a dental abscess who needs antibiotics, I am not going to give them antibiotics because that's Richard's problem. I'm going to ping the patient over to Richard and say, that's your ball, go play with it.
This is where this flexible commissioning, if it had been allowed to develop, that's where that absolutely comes in. Because you can, if you get let's say a child with toothache or something, which you shouldn't, but you do, then you can refer directly and then they won't go onto the waiting list, the 2,000 odd that I was talking about, they will get seen. And yes, it's great if, but they changed the rule. There were 15, there's now 5. They changed the rules so much more draconian that 10 other practices said, do you know what, forget it. But back to what you were saying, all these ideas are great. And it'd be great, wouldn't it? That must drive you nuts, people come in with toothache. Well, go and see a dentist.
But actually, if we, in theory, worked together and sat and said, actually, flexibly, how could we do it better? Give the pot of cash to us. Let's not worry about that law because actually there's a way that we can redesign that with politicians. You're not going to send a patient to me because of that stupid guideline that says you can only do it for 1 to 17-year-olds. And I'm not going to send them to you because I know that you're not allowed to. Actually, let's work together to do that. That is what's trying to be delivered in the neighbourhoods. Now, the challenge I have to that is that's not actually what's happening. What's actually happening is we're now sat on a sofa next to each other, so we're now called a neighbourhood. Nothing has actually changed. You still have your rules. Mm-hmm. You've still got your rules, I've still got my rules, and we've still got our pots of cash. Just because we're now called a neighbourhood and we are next to each other and we're forced to have meetings together, nothing has actually changed. So what needs to change is our rules and regulations of how we work with each other and how we spend money together, how we are rewarded together, and how we are nudged in the right direction together to do what's best for the patients.
And at this point, the neighbourhood plan and going forward is all about prevention rather than cure. So the third sector, the voluntary sector, the community sector and the patient voice is supposed to also be in this room so that you are dealing with people and you can get their electricity bills helped and do all of that so that we can have that conversation. We're supposed to be all in that same room so that actually you're going to see the patient less because we've fixed the boiler. We've done this. We're seeing you. We've got this way of working. That's the way that it's supposed to be working. That is the neighbourhood plan. That is what Doncaster's looking for. But yes, the question is, or the thing is there, is we've all still got the same rules.
Yes, absolutely. And coming to that again, if we change the rules, you wouldn't come to the GP to complain about your boiler. Could you imagine going to your GP and saying, I have a boiler problem?
But being able to speak to the community and have that out there going, I can't afford to fix that, straight off means that the community around us, the neighbourhood,
yes,
can start to fix that so you don't get the elbow problem in the first place.
Yes.
So you will get more money in, but we need to have that working together for neighbourhoods to work. I actually wrote a question about neighbourhoods, and I'm going to throw this at all of you, which would be, So we've got an idea of neighbourhood supposed to be very local, like a village looking after. That's what it's supposed to be, the village looking after the rest of the village. We'd also solve isolation and loneliness because we'd all get out there. So if you've got the neighbourhood plan going forward, the question in 2 parts is to all of you. What one thing would you include within the neighbourhood? And within what's out there, what one thing would you take out to make it work? Oh, how'd you get silence out of everything?
Wow.
I'm assuming that one of the things is you're going to take out the boundaries.
Yeah, so, okay, so...
So one thing that you definitely want including in the neighbourhood to make it work,
Yeah.
I'm going to send this to Wes. And one thing that you definitely need taking out that they've put in is a rule.
Can I go first?
Yeah?
I think the one thing, and this builds on what I said before earlier about pharmacy first, is I would take that, but I would make that fit for purpose for the needs of that neighbourhood community. So i.e. any minor illness, condition, anything like that could go to the pharmacy, and if you're entitled to free NHS prescriptions, you should receive an appropriate evidence-based treatment that we know is going to do some good, help manage that, and that's free of charge. So it's like what we would call a minor ailment scheme as well alongside that. So it takes away that burden of people feeling that they need to go to the GP or they need to go to accident and emergency for that kind of input. I think empower the pharmacies and let them do what they're skilled and trained and able to do, and give the communities that support. That's the thing I would take and do. What would I take away? I'd take away this ridiculous competitive commissioning arrangement that we've got. I'd just scrap it completely. And vaccination services, for example, is something that I think GPs and pharmacists, alongside our community nursing immunisation teams, we can all work together really well on, because actually if it was all coordinated, we've done it before, we did it during COVID, didn't we? Why have we not taken that forward and continued it at an ongoing scale at something that's sustainable? So there you go, there's my piece.
Okay.
It's difficult for me, if I start with the taking out, it's difficult for me to take anything out because dentistry sits in its own entity that is completely separate. Our money comes from the Business Services Authority in Eastbourne, and it's just completely out with anything that we're not in competition with anybody. You know, like you're saying, you've got vaccines that you could, you know, because we are just what we are. So I still feel that in lots of ways, dentistry is a bit out there left field. It's not in the NHS as such. But in terms of what you would bring in, I would develop what was the flexible commissioning scheme, so that if people do end up in the wrong place, if they do go to the pharmacy with, can I have some antibiotics, that you could directly refer to the right person, not just say to them, you need to see a dentist, and they go, oh, I can't get a dentist, but you've got the ability, and dentists can do it back the other way when they're seeing something they think, actually, this might be oral cancer, bang, straight to you, or whatever it is, so that there's all this interchangeability between the different groups of people, but not just telling the patient you need to go and do it, that there is a direct referral route for it. And follow up as well, because just because you've referred somebody doesn't mean that they turn up.
So, to put in, it's a bit of an analogy, this one, but I would put in grandmas. Grandmas. You know, the society is missing grandmas like mad. The thing about grandmas is that they kept everyone together, and they educated people, and they passed on how to look after yourself, how to feed yourself, how to solve problems, how to raise children. So I'd give everyone a virtual grandma. You know, whatever that may look like, we need to bring back communities rather than geographic communities, people who support and help each other. And in countries outside of England, grandmas are often seen as that figurehead. They're the people who keep the community healthy. They're seen as the one who's most economically active, because somebody who is younger can work because the grandma solves the life problems. So they keep the economy growing. Grandmas keep economies growing. So I would bring back virtual grandmas.
So I'm just going to put it out there. The solution is women.
Yes.
Cool. Just wanted to get that there. Solution is women.
I'm quite happy to actually second that. Very honestly, women are an untapped resource. And I say that apologetically. I apologise because the world has ignored women largely. You may or may not know that most research that we have about the efficacy of drugs, about diseases, is not based upon women. What I know about medicine is not based upon women, and I'm so sorry. The drugs that I use are not designed for you, it's designed for men. When I make a diagnosis, it's not actually designed to solve your problems, it's designed to solve men's problems. Society is designed upon keeping men active. The reality is, and even if I was just thinking about this really bluntly and honestly, if we solved women's problems, we could contribute trillions to the global economy just by keeping women fit, healthy and active. I'm sorry, we have let you down.
I hope you speak for all men. Unfortunately, I know you don't. So you were going to add something of what you're taking something away.
And what I'm taking,
then, am I right that you want something to add into this? So let's take away.
What I'm taking away is boundaries. So Richard beautifully said the other day in a conversation we were having about dental health and cardiovascular disease, heart disease, brain disease. Teeth are integral to that. If you don't have good teeth, you are more likely, or it is a trigger, a cause for heart disease. So I want to know that in my patient, I can refer to Richard, book into Richard's clinic, get a health checkup, a cardiovascular checkup based upon dentistry. I want to know that when a patient has a medicine problem that I don't understand, I can book in with Joe and Joe will solve it. And at the moment, we can't do any of that because of these boundaries. So I want to take away boundaries.
Okay. You had your hand up, so go on.
I'm a lecturer here at Denton College Group. I'm also a district nurse. So one of my questions is about the district nursing, the walls without, the hospital without walls. And we take everything and everybody, there are no criteria apart from one, and that is that our patients need to be housebound. However, my question is for the GP. On a weekend, all of your nurses' patients come to us. Those who need dressings on a weekend all come to us, and they're not housebound. So when we talk about the future plan, what is the plan on the GPs opening at a weekend so their nurses can see our patients?
Okay, so the question is, what's the plan for GPs opening at the weekend? At the moment, there is none. So we spoke earlier about having thousands of unemployed GPs. And I mentioned that I would like to employ those GPs, but we don't have the finances to employ them. Let's pretend for a brief moment the government gave general practice a huge dividend and said, actually spend it how you want, spend it on your GPs. And we employed those GPs. So thousands suddenly come into the workforce. We're still approximately 8,000 GPs short of being able to deliver a decent service for the current population. Now this sounds like a bit of an oxymoron. We have unemployed GPs, so in theory we've got an excess of GPs, but I've just told you that we're somewhere between 8,000 and 10,000 GPs short of being able to manage the NHS. So I need you to just think on that for a moment. If we were going to run a decent NHS GP service at the moment that is senior led, i.e. you can see a GP when you need to, we need at least 10,000 GPs. From start to finish, it takes about 10 years to train a GP. There is no way within our generation of getting 8,000 to 10,000 GPs without stealing them from a different country. If we stole them from a different country, it's on such a scale that it would deplete that country of its brain. We would harm that country. We would also have immigration problems based upon the current political rhetoric in the UK. Imagine taking 10,000 doctors from the African continent at the moment. It's unheard of, it's not going to happen. American doctors are not going to come here, Canadian doctors are not going to come here, doctors from Australia and New Zealand are not going to come here. So the doctors that we're going to access are from the African continent. That's not going to happen. So we can't train our own and we can't steal 10,000. So there is no decent plan for a general practice service within our generation. The plan at the moment is to use anybody but a GP. So a huge amount of money is being invested, and that's why we're now given these pots of cash. You must spend it upon a physiotherapist. Why? Because I'll spend it on a GP otherwise. And they don't want me to spend it on a GP because they'll quickly go and then I'll complain about being no GPs. So instead they say you've got to spend it on a physiotherapist. And that's what's happening. So one of the questions I'm sure that I have no idea why it hasn't arisen yet, but why can't you see a GP? Well, we don't have any. We're not going to have any. and that's within our generation. So get used to the fact that when you turn up to a GP practice, there is no GP.
So off the back of that then, why don't you open the surgery at a weekend and employ district nurses?
Boundaries. Okay, so the question was, why can't we then just open it at a weekend, for example, and employ district nurses? So district nurses are employed by a community trust. And again, this is different for different areas across the UK. But in Doncaster, we have a community trust who employs the district nurses. To take you from that trust, I would have to steal you and poach you. I would have to at least match the wage, if not...
We used to work together, didn't we? We used to be based in the GP surgery.
Yes, because district nurses were usually employed at that point by the commissioner provider, which at that time was something called a PCT. And they essentially said, we'll pay for them and we'll house them with you. So essentially they're yours. We'll pay for them, but they're yours. Now, district nurses belong to a different organisation. To poach you from a different organisation, I need better terms and conditions, otherwise you're never going to jump. What cash have I got to do that? What space have I got to do that? And I would harm a colleague organisation. I don't want to steal your pharmacist. I don't want to steal your dentist. I don't want to steal a district nurse. I want us to work together, not steal you. So the question then that might be asked is, well, why isn't your service just working hard on a weekend out of my practice? The reality is that actually I can't bring you into my team because of all of those barriers that I've just said. Sadly, at the moment, you belong in a different team and I can't touch you. Annoying, isn't it?
To the neighbourhood.
My question on the back of that is, who do we need to speak to change it? Because the barriers, so we can overcome them.
Great question. So the question was, who do we need to speak to help break down these barriers so that we can work together?
Yeah.
And I've said this on a number of occasions, but it's probably not going to get us anywhere because it's the MPs.
It's who?
MPs. To make all of this happen, laws have to change. The Health and Social Care Act has to change. To make that change, you need a number of GPs in the House of Parliament putting pressure upon the Department of Health, discussing it in Parliament and saying, yes, we agree, let's change it.
So why can't we do that?
That's up to you. So I'm just a voter, just like you are. I can write all I like to Wes Streeting.
But you know that side of it, the side that, ordinary people don't know.
Yeah. So I need to influence the public, the general voting public, to change the law. I'm just me. I'm a guy in Doncaster who's got practice with 6,000 people, whereas you have the entire Department of Health who wants you to be okay seeing anybody but a GP. Now let's come back to the question, why do they want you to see anybody but a GP? Now I don't want you to think that I'm downplaying my colleagues. They're professional and they're brilliant, but they're not a GP, nor am I a pharmacist, nor am I a physiotherapist. But my question to you then is, why do you think the government don't want me to have a bunch more GPs?
Because you cost too much.
Yeah, I'm really expensive.
But people need to see a GP to get to other services.
People,
Take that away.
so
Let the practitioners do it.
people don't necessarily have to see a GP to get to another service. People can see my practice pharmacist, and the pharmacist can help access another service. You can see my physiotherapist. Yep.
And this is where the neighbourhood health comes in,
Yep.
because in principle, yes, we've got boundaries. Yes, there's issues within the neighbourhood health of going forward. In Doncaster, we do have a lot of passionate people sat around that table who are working. One of the things that we're doing is ask the expert. We're doing this so that you're educated, that it's not the GP who doesn't want to speak to the pharmacist, the dentist who wants to see you to get it sorted. We're trying to educate people to say, the problem here is the fact that the government, whichever colour they are not listening to people. We could get it from a neighbourhood point of view, whereby you wouldn't need to, you would understand that, going and seeing Jo is the best person there, that she can refer you on to the physiotherapist, that all of this is there. We've got help and support from the community. So if you've got problems with your housing and what have you, we would be able to deal with all of that. And that's what neighbourhood health is supposed to be working towards. In Doncaster, we are lucky, as in the fact that there is a lot of people working for this tirelessly. We've got boundaries. We've got the fact that the bit that gives us the carte blanche, the open pot, the script of how to write this, we can't, because even with this, their idea of neighbourhood health, they've tied our hands already, okay? The government. Yeah, because we can't just scrap the boundaries. We can't have it whereby these two aren't competing with each other. The bits that we need to take out are the bits that we need to talk to the government about. The only people who can do that are the voters, are you lot. So here today, we are here to try and show what those boundaries are, show what those issues are, so that you can write to your MP and go, look, I heard this, go watch it. I want you to go to the government. I want you to turn around and say, let's make neighbourhood, village, community, let's make it work. And to do that, you need to listen to them. That's what we need from you. Instead of ask the expert, ask the audience. Please write to your MP. Please help us, because I hope you can see that if you put even the likes of Shelby, you could come up here because you work within different things, but put the likes of us all together in a room, and we've solved it. But you've got to take out politics, and only people can do that. We can't. Well, we can from an individual basis, but we can't actually push it forward without your help. So I'm asking back, please write to your MP. Tell them to watch this, tell them to do something.
So, the brochure called it for the future, which talks about the 10-year plan, and I think everybody in this room would agree that providing services much closer to where you live, all those three legislations are the right thing to do. I think they're also really, there's no extra money that goes with that, so it's almost like you're hoping when the guidance actually comes down that it does sort of hint at that one pot of money, and then you guys just go out and do what you need to with it. I mean, I work for a mental health and community trust, and there's nothing more expensive than somebody accessing specialist mental health services on an inpatient ward. It is so expensive. So wherever possible, we don't want to plough all our money into that. We want to plough it into the community to stop people actually having to come into our services. So the principle of it is a really good principle, but the devil is always in the detail, and we've not got that. Yeah.
Can you sum up that? Because the audio won't necessarily pick that up.
Yeah, sure.
So, because there was a lot that was said that's very well. And I think also to pull in that in this neighbourhood, there's community, there's pharmacy, dentist. We also need to add in that in there is also the acute trusts that are in part of that.
Yes. So as a health economy in total, hospitals, mental health trusts, dentistry, pharmacists, GPs, the voluntary sector, the local authority, everyone working in that health environment is wedded to the concept of needing preventative health care. We all want to keep people well. When you get ill, we want to keep you at the lower level of being ill rather than it ever escalating. If it escalates, it's catastrophic for the person. It's catastrophic financially for the system. There is no good reason for us to allow people to progress to being more and more ill. So we all buy into the concept of redesigning a system that is based around preventative health care. The challenge, though, is the current plan isn't a plan. It's a manifesto. It has no details about how we're going to get from where we are to a preventative healthcare model. So we're asking, if you want to go on that journey and create a plan, our ask to you, or my ask to you, is to break down those barriers and empower us to be able to deliver preventative healthcare on your behalf. Don't dictate to us from government what you think is going to work for Doncaster. The only people in Doncaster who know what's going to work for Doncaster is Doncastrians. We will ask you, we will deliver for you if you remove the boundaries. But we're not there.
No, we're trying. So on that score, we really are. We are actually past the time of it, and we haven't got over the first section on that score. I don't know how long we have the room for. In fact, I do know we have it for at least another 15 minutes. I'm rubbish with time. I don't mind going on a little bit further. I don't know if anybody else does, because I haven't talked about men, haven't talked about women, and we haven't talked about the menopause. And the reason why I was trying to talk about the menopause, to me, throws something else in. Mainly a conversation from yesterday. If we've got time, I might throw this one in, if everybody would like to. So, and the reason being is because it was an interesting one. So if we're looking at neighbourhood health and talking about this, talking about the fact that women are overlooked. 50% of the population, roughly, are going to go or are going through the menopause. Yet it has got to be one of the worst things possible, because no doctor, in the nicest possible way, know anything about it. So,
I didn't argue against that fact.
no.
A minority.
Minority, yeah.
Female GPs might.
It's not, well,
No, actually, as a female, I've had more issues going and talking to a female about the menopause.
yeah, it's generally not well understood.
No. But there was something that you pulled up over, is there a place for pharmacists over the understanding, because the understanding on this. So again, is this something to throw in to the neighbourhood, to the way? Can pharmacists, can doctors? Can you sort the menopause issue out, Joe?
Bring it on. As a perimenopausal woman, bring it on. There's nothing like having a lived experience, is there, to sort of make you the expert in the room. So this came on the back of the conversation. Fran came along to the local Pharmaceutical Committee's meeting yesterday, and we had an interesting discussion, because one of the services that pharmacy has had commissioned nationally over the last couple of years, which is fairly new, is the provision of the contraceptive pill as a service. So women can go in and access both to start a pill, but also to have repeat supplies of the pill. And as from the end of October this year, all the pharmacies that are offering that service can now offer the emergency hormonal contraceptive too. So there seems to be some recognition that pharmacy has a role, have the skills, the competencies to be able to support ladies with their choices around contraception, but also importantly to make sure that they are safety netted, so that if there's anything that needs the attention of a doctor or a more specialist service, that they have that knowledge and are able to signpost a woman appropriately. One of the, I know menopause has been quite a hot topic. I mean, certainly I'm in that age group. I'm in Davina McCall's sort of category of age. And yeah, go girls. We are certainly getting the message out there in terms of the really significant and quite disabling impact that a loss in your hormones can have. And we talk about medical misogyny. I don't think there's any bigger scandal than the whole sort of evidence base that basically scared women 20 years ago away from taking any form of hormone replacement therapy. And that's never really been corrected, has it? The literature still to this day, if you open up the packets, will warn you off it. So I got on my soapbox a bit yesterday, didn't I, Fran? And I said, we have got something ridiculous, like if a lady has issues with her hormones or needs a more specialist piece of advice, GP colleagues, with the greatest of respect, unless they've gone and done the additional specialist training, how much training do you get as an undergraduate medic?
In menopause, go read this chapter.
That's it. Okay, pharmacy's not been much better, to be fair, although we do have a really good understanding of all of the different formulations and the methods by which the drugs can be administered. So we've got a little bit more of a head start, in my opinion, with regards to supporting somebody. But at the moment, if Dean was to refer me to a more specialist situation, was it a 62-week wait?
So I did
Before I would
actually like
get
it was
a
55 beforehand, but she came with the up-to-date 62-week wait to be able to be referred into the menopause clinic. The feedback from the menopause clinic, from everybody who was there, was this is life-changing.
Yeah. And
it's proven that it's absolutely brilliant, but you've got to wait at the moment 62 weeks to get there.
It is.
And the looks of women in the room, it's just you go surviving over a year without any support ultimately.
Absolutely. And as a lady who 3 years ago was absolutely wiped off my feet because of hormone imbalance symptoms, I couldn't have imagined. I actually paid and went to see somebody privately. Now, I was very fortunate because I'm privileged and I can do that. But the point I made yesterday is how many of our population are actually living with really severe disabling issues. They won't be able to work. There's a real mental health risk here, and we know that ladies of a certain age, when they hit menopause, perimenopause, there's a greater risk of suicide. That to me is just a social tragedy, and we should be doing something much more about it. So yeah, bring it on. Let me work with Dean. Let's get a proper neighbourhood support service in place where women can go to and issues around hormones and the replacement of hormones in a safe way, where they're supported, it's responsive, and it helps them live the best quality of life possible. Wow, wouldn't that just be brilliant?
So you've talked about grandmas, and in the same sort of theme as that, peer support, lived experience, you know, just getting in the room with people who understand what you're experiencing, and, you know, there might be a long way for medication or hormone replacement treatment or whatever, but in the interim, you've got you speaking to peers who understand what you're going through. So I think the grandma concept is perfect for widening that up to peer support.
But let's not medicalise it too much, you know. Let's just make it about people with similar experiences,
And so from the neighbourhood plan, this is one of the things that's sort of missing, because prevention, that's what we're after. That 62-week wait for all those women to get the support now, that's not classed as part of the plan, that's not classed as part of it. But how many times is a menopausal woman going to end up at the doctor's surgery, and a lot of them put on antidepressants, which is definitely wrong, so it's going to cost you more to look after that person where you're the wrong person to be doing it.
And the risk of cardiovascular disease, you know, so heart attacks, strokes, diabetes, that's all associated with having low physiological hormone levels.
And with menopause, possibly try and explain this to me, but women tend to present really late.
Yes.
They put up with it for such a long time because they think, you know, it's just a natural phase of life. I should be able to be okay with this. And they come when they're at their wits' end, as if they, I just can't do this anymore. It's too late. Well, not too late. They're never too late, but it's not early enough.
And it's that stoicism around it. It's that there's been that sort of perception out there that, you know, you're somehow weak if you needed HRT.
But you've got to remember, we've had a lifetime that if you go to the GP, you're on the spot here, but if you go to the GP being told, you know, I've got really heavy periods, I've really got pain here, this, what, and the other. Yeah. And so I'm being told from men or women doctors, suck it up, that's what you've got. Suck it up and see. That's the way that it is. So we have been conditioned to accept the fact that it is just normal to suffer. I mean, had we have got a lot into the women's health, which we haven't got to, I know people who've had endometriosis, whatever it is, you can say it.
Endometriosis.
Thank you. 7 years they can battle over being diagnosed because they are just told, oh, it's just really heavy, it's just period pains, whereas it's something completely different. So by the time you get to the menopause, you've got to the point where nobody is going to listen to you at all.
Perhaps this is a chat for another day, but I very much advocate for this concept of women in every policy. In public health, there's this concept of health in every policy. So when you're thinking about designing a road, you think, well, what's the impact upon health? When you think about how many more takeaways you're having, what's the impact upon health? Well, actually, I advocate for the concept of women in every policy. How's that going to affect women? What's going to happen now to our women population if we do this in society? I would love that to be in businesses. I would love that to be in our local council. Because I was going to say for so long, forever, we have literally ignored women and created a society around men. That's got to change.
And earlier on, we did say that women are the solution.
And we need to be looking after our future grandmas, don't we?
Absolutely.
Especially if they're going to be the linchpin behind that.
And grandmas are the way going forward. So you've got to look after them, sort of thing. I do want to do something, and there is a reason behind it, okay? Because we are going to have to, a couple of people are gone. We're heading towards 5 o'clock already. I go out and I ask people questions, okay? And I had the men, the women, the youth. Women show up. I haven't asked half the questions. We're obviously going to have to do this again. But they come and they show us the questions. They ask the questions. They are there, they're involved. One of my questions that was going to be, was for men, but it was also youth, okay? So it was going to be my question about men's health, right? And the question was going to be to all of you is not one man came forward with a question. Not one man was concerned enough or involved enough in their health. Does that, as medical practitioners, does that scare you?
Happy to go first. Yes. So I've just mentioned that women tend to present late for problems such as menopause. You've mentioned it can take 7 years before you start to think of the concept of endometriosis. Men tend to bury their head in the sand and just push on and ignore it until it hits a wall. And then usually actually a woman in their life says, come and get this sorted, because they get worried about them. And they tend to come to the GP because somebody has pushed them to go. One of the biggest killers in men, other than alcohol, drugs and suicide, is cardiovascular disease. So heart disease, brain disease, because your arteries are furred up. And that usually tends to occur in men as they get past the age of late 40s, so early 50s. That might start to kick in a little bit as a bit of shortness of breath when you're walking, a little bit of tightness in the chest when you're walking. Men won't present at that point. Men present at the point where they've got this crushing central chest pain that's quite clearly a heart attack, and they have it at home and their wife is scared and says, you've got to see somebody about that. Or they drop dead at the gym. They go on the treadmill, they go for a run because they think they're unfit because of this shortness of breath, and actually it was their heart screaming. They push it when they're on the treadmill and they drop dead. So men have it in them, or they're educated into them, that you're okay, keep going. Now, I've just spent ages talking about how society is not designed for women. We haven't done research on women. We've done all the research on men. But what we haven't done with men is to empower them to reach out for help. Young men are taught, push on, you'll be fine. Be a man, man up. We've all heard those phrases. And sadly, that results in early death for men because of late presentations for diseases.
And all of these things, if caught early, are preventative.
We've spent a long time now talking about neighbourhoods and the move to preventative health. Preventative health will have to be a change in a mindset of a generation of men of, I need to look after myself. That's a whole different challenge.
So at this moment, if I put it out there, okay, on social media and what have you, to all the loved ones of the men out there and to the men out there, what one piece of advice do you want them to hear that's going to change it? And to their loved ones, not just to them.
Yes. It's hard to narrow it down to one piece of advice. The main thing that is going to kill men in their 40s and 50s is cardiovascular disease. Cardiovascular disease started 10, 20 years ago, 30 years ago. It didn't happen when you were 50. It happened the first time you picked up a cigarette. It happened when you started to eat more burgers and went to the gym less and stopped thinking about your body and your waist size. So I don't want loved ones and men to turn up at 50 when you're already in trouble. I want you to start being conscious about your own needs in your youth. Yes, as a man, we're told to look after the family, work hard, play hard, but you have to look after yourself hard too. So I'm going to give the piece of advice I was given when I was a training junior doctor. When you're a junior doctor and you're wandering around the wards, you've got a list of patients, you've got all their names and you've got the conditions next to the side, and it just grows throughout the shift. I need to go see this one, I need to go see this one. And I was taught as a junior doctor, put your name at the bottom of the list so you don't forget yourself. Now I've changed that over the years to put your name in between every single patient, because you have to recalibrate yourself and check yourself, because that list will continue to grow and you will never get to the end. So if I'm on the end, I'm never going to check up on myself. It needs to be routine that I need to be in good health to look after the people around me. So men, if you want to look after your families, you have to look after yourself, otherwise you cannot look after your families. Please put your name in between every single stage of what you do.
Anything to add to that?
Nope. Very eloquently put.
Very beautifully put, yeah.
And I suppose the other bit that I did have in there, as I said, there was lots, is that the other people that we got no response from is the youth. And when I asked my children why not, the response was, well, I've got ChatGPT. So, which is good. But is there any advice? Because again, I can put this out there. They might listen to social media from any of you. Is ChatGPT good enough? What should the youth be thinking about their health?
As somebody who uses ChatGPT from time to time, I can say wholeheartedly, it can be a really useful tool. However, you have to have the right tool in the right context. And sometimes ChatGPT can't filter that context out. It will just scour and take all sorts of bits of information that are out there on the web, and it will try and mesh it together. And actually what it's talking is complete, utter rhubarb. So don't believe everything that is written down by ChatGPT would probably be my biggest piece of advice, and that's what I've said to my kids. Find a safe, trusted place to go and test it out. Yeah, use it as something to probe and ask, and use it for asking you questions. Use it for bringing your ideas, your concerns, you know, what you're hoping to get out of a consultation. Fine, but don't take what it recites as being the absolute gospel true evidence-based, because it isn't.
Anything to add to that?
No, I agree entirely. You know, ChatGPT, AI, is based upon popular answers. Yeah. It scours the internet and the information that it has to figure out what everyone else always said. But no, not everyone's always right. So if everyone says this answer, ChatGPT will give you that answer. But actually, the answer might be subtle, might be slightly different in your case. And that's where the human level comes in, that push for a little bit more information. ChatGPT will give you the popular answer, not necessarily the correct answer.
It's going back to being a grandma. Go speak to ChatGPT, then go check with grandma to see whether she thinks it's a good idea. I think we are going to have to call it a day, which is a shame because I've got so many more questions in there. Anything from each of you that from today you would like to say as your ending of whatever? Anything?
Yes, because you didn't let me answer that bit.
Which bit?
The bit that you were just doing with...
Oh, sorry. Go on, ChatGPT. Sorry.
No, it wasn't that. It was what advice would you give to young people?
Ah.
It's not just young people, but they've got... You start off with a clean sheet in dentistry. You've got perfect teeth. We know what causes tooth decay. We know how to prevent it. Prevention in dentistry is far, far better than cure. I haven't had caries for nearly 50 years. But all the treatment that I've subsequently had is because I had tooth decay when I was 6 to 12 years old. Because once you've got a restoration, it needs maintaining for life. Don't get them. We know what causes it. Don't do the energy drinks. Don't go nuts with sugar. Clean your teeth. Clean in between them with little TP brushes. You won't have any problems. And you won't have any problems 50 years later either. There.
There you go, advice.
I need to put you on the spot for the end. You haven't answered any questions.
No, but I asked them.
Yeah, so if it's all right, I'm going to put you on the spot for my end bit.
No. Go on.
If you had to ask us, in our new integrated way of working with no barriers, to solve 2 or 3 problems on behalf of the Doncaster population, on behalf of Healthwatch and the People's GP, speaking on the behalf of the population, what do you want us to sort out?
Communication. Straight off. Communication is key. Understanding how to talk to different ages. And we've talked about the fact that kids use ChatGPT, but they also don't know how to interact with people. They might be able to do it on this, but they can't have a conversation. I would like all of you, as the responsible people who understand it, to learn how to talk to young people. I'd like you to be able to understand that the population of Doncaster reading age is 9 years old. Stop talking to everybody as if they've gone through the same medical degrees that you have. Stop allowing the NHS to have these such corporate things. We are blind to all of it that comes in. Be human, actually talk to us, and have that as that understanding. I'd like to see the community bit come back so that we've got that thing. So to me, understanding how to communicate with the patient, knowing that you're the one that's going to lead it. We're not going to lead it. It would be lovely to think as patients that we would, but we're not, because we don't know what we don't know, and we're just going to sit there. So I think that's the first thing. Please communicate to us well. I can't remember what the question was completely, as in...
What do you need us to do when we're working together?
Yeah, communicate.
So if I communicate better.
So just communicate, because from there, and help educate us, which is what this is about. Help educate us. The younger generation, I mean, it's got nothing to do with health, but, you know, knowing what boiling water looks like, you know, that gets Googled nowadays because they don't know how and don't know what it looks like. So educate us, because otherwise it's just going to end up with more of a fear of, why do I talk to you? What do I do? We've got a population out there of younger parents who are going to A&E with a small toddler with a cold. We need grandmas again. But help us to educate us. What do we need to tell our younger generations of how to look after themselves, and work with the communities so that we can help communicate it and educate them in a way that works for them, not a way of somebody who's got a medical degree. Everybody on here, whether they like it or not, we're all privileged because we're educated, we've got an understanding. And it's one of my soapboxes of why you shouldn't get rid of Healthwatch, because there's so many people who will stop that voice, will stop talking to you. They will stop talking to you because you're not doing it in a way. We need you to be the people that help educate us, that help do that.
Perhaps we need to fill this room with our grandmas next time.
If you had all of the grandmas together, you would change. Every neighbourhood village just needs one grandma. She'll bring in the rest of the grandmas. So, and we will solve everything. So women and older women are actually the answer to everything. But there you go. So back to you. Because you've got away with not answering.
Oh, I thought I had a great little technique there of getting out of it.
No.
So was my question about what would I tell young people?
No, I think it's what's one thing that you'd like everybody to know. If there's one message out there, the one thing from today that we haven't managed to talk about.
You know, I'm going to stick with the grandma thing. I am going to appeal to you and say, can we do another one of these? Can we call it a grandma's group? Invite the grannies from across Doncaster and begin that education process. I haven't heard anybody yet disagree with the concept of education of people to improve healthcare and to improve prevention. We need to recruit an army of volunteers who are willing to disseminate that information and pick our brains until we've got nothing left to give. So what I want, you know, for people to take away is consider contacting Fran and volunteering as one of our grandma army.
So you want a grandma army? Yeah. Okay, and we'll educate it. And then I'm going to throw in, go on.
When they take Healthwatch away?
When they take Healthwatch away, do you want where it's going if they take the patient voice away at this moment in time? And it will not be politically nice, if you want the truth. So, the way that it works out at this moment in time is in approximately March 2027, Healthwatches will be abolished. I can understand that they wanted to streamline, they wanted to do things. But the government didn't look at local health watches. They didn't look at what they're doing at a local level. What they have stated is that they want the patient voice to be louder. And to do that, they're going to give the patient voice direct to the NHS, direct to the local authority. I'm going to go back to privilege, okay? So at this point, everybody in this room, pretty much, is going to have a voice because we know how to communicate. We know how to articulate, and it doesn't bother us. So off we go. We're going to go to the NHS. We're going to go to wherever, and we're going to complain, okay? we're going to get a wonderful letter back. It's going to mark their own work, believe me, so they'll have this. They're going to use big words, abbreviations. We're going to have Google, and we're going to be able to go back because we're educated enough, we're privileged enough to have that as an ability, okay? So what's going to happen when they get rid of local health watches is that the voice of, and I'm going to be really unpolitically correct, the white, middle-class man or woman is going to have that voice, okay? That voice is going to come up and they are going to be heard. And that's all the government is going to hear, and they're going to correct that. So the whole of the health service is going to become middle class and privileged because that's what they're going to do. The voice of the inequalities. BSL users, it's not their first language, English. So how on earth are they going to speak up? People with learning disabilities, how on earth are they going to speak up? They're not. Nobody is going to be there. Nobody is going to speak for the inequalities. And if you raise inequalities and pull up the healthcare system based on that, everybody benefits. Instead, we are about to create an NHS that will be based upon the privileged, educated person, and the rest of the inequalities won't be heard. That's what's going to happen. What am I doing about it? I'm making sure that I'm loud enough to say you can't get rid of it. You can't get rid of that voice because it's too important. There's no point doing neighbourhood working if we're not prepared to listen to the village, if we're not prepared to listen to the neighbourhoods. And at the moment, we're about to stop being able to hear them. So that's where we are.